Good evening, folks. David Rawson here. So Dr. Witmans, who is a physician, is a board-certified sleep specialist. She has collaboratively worked with dentists over the last 20 years. You need to know how jealous I am of Alberta people. We need more people like her. She's been able to work with dentists over 20 years to manage airways and associated sleep disordered breathing. Currently, she has a busy private practice in Edmonton. Her expertise in sleep medicine has enabled her to play an integral part in the development of current international guidelines on the use of polysomnography in pediatric respiratory and non-respiratory sleep disorders. She has published several publications. She has several publications and collaborations to her name and is a sought-after journal and grant reviewer. She's involved with numerous committees to help address sleep problems in children nationally and internationally. It is a pleasure to welcome back to our stage Dr. Manisha Witmans from Alberta, who's going to speak on interdisciplinary synergistic care of patients with sleep apnea. Welcome, Dr. Witmans.
Thank you. Can everyone hear me okay? I just want to check the mic. Dr. Rawson, thank you for that really warm and gracious welcome. I appreciate you giving up some of your time today. I was just looking at some of the participants. I'm so thrilled to see my colleagues here who have come on, as well as the medical director of Sleep Image. And I'm hoping that there'll be time to ask her questions as well. Thank you all for joining in, and for the people from Edmonton, welcome, and from people from elsewhere, thank you for joining us. So, I was reflecting back on this talk, and sleep apnea sure has changed in 20 years, from the first descriptions where people talked about enlarged tonsils and adenoids in kids and pulling them out, to the CHAT study where it showed that 7 months of watchful waiting resulted in 46% normalizing their sleep study, to now we're talking about whether tonsils and adenoids need to come at all. And it's really made me think and reflect back about what we're doing and how and where to go. So I hope to speak with you about this journey and welcome your thoughts and insights about what we could do different going forward. So I wanted to talk about sleep disorders evaluation from an airway and breathing point of view, and discuss limitations of our thresholds for treatment. Dr. Remmers already spoke about that in spring, about the limitations of the AHI and how we quantify that. One of the dentists asked me a very important and smart question. He said, if apneas are only counted if they're 10 seconds long, what happens if the apneas are 9 seconds long? Well, they wouldn't be counted in the threshold. And so is that a problem? You could see why it would be. And then discuss how we can all work together to help the world sleep and breathe better. So before I continue the talk, I want to tell you that I'm the medical advisory board for both Vivos and Sleep Image. And I can even tell you why. I get asked to do all sorts of things. And the reason I like these two particularly, and I'll highlight them just briefly in the context of this talk, and if you have questions, like I said, you should talk to the people that are here. But why did I want to get involved with them, and why do I support them so much? Because their premise is why, that there's got to be a better way than we know. Vivos is looking at, expanding the airway, and I'll show you a couple of slides as to why that makes sense. And we're working on emerging data, and Sleep Image, they have shown that there's a better way, and it correlates very well with an overnight polysomnogram, and it has opportunity to provide this data at home, which is in fact, just genius and so accessible for all of us, and gives us more opportunity outside the overnight polysomnogram. So you already know and have heard from many people that sleep apnea has significant neurocognitive, behavioral, metabolic, cardiovascular morbidity in children and adults. There's not one thing that sleep apnea doesn't touch, and it's common through the lifespan. No one is spared from it, birth to death. I actually spoke to a mom of a 3-month-old today who had an apparent life-threatening event, and she's seen Dr. Haidt, and reasonably so. She's terrified because she had to intervene to help her baby and worries about him, and just even the process involved in that. And I think it's important to tend to the phenotype, or what we actually see of the patient, and address the root cause to match the best treatment options and the individual patient to improve patient outcomes. If our outcome is health and well-being, whether we get that with an appliance or exercises or weight loss or CPAP, really depends on the patient, because it's not the same across the board. To me, it's like saying that, everyone just can exercise 3 times a day, and eating at McDonald's for the 3 meals won't make a difference. And we know that's not the truth. So if I reflect back on medicine in general, particularly sleep apnea, I think we're troubled by the story of the 6 blind men and the elephant. We all are in our silos of what we think. If you humor me for a moment, the dentists evaluate the tusk, and the tusk, it looks like a spear, and they know what they know. And I'm the airway guy, so the trunk looks like a snake, and maybe that's ENT as well. They know what they know, but we don't take into account the ear or the tail or the leg, all these things at different parts. So we all have to take our blinders off and appreciate the elephant for what it is, and honor the whole elephant as it is, and then think about how that elephant might exist and how we might help that elephant function. So sometimes it's the ecosystem and the environment for the elephant, and sometimes it's more. I'd even challenge you and dare you to say that we only know a part, and we need to work together. So can you imagine if we think about that elephant and focus on the ears and give him giant ears, and that's Dumbo on Walt Disney. And if we think about what India might think, it was Lord Ganesh's celebration, I think about a week or 2 ago, because they worship and celebrate the elephant, who is Lord Ganesh. So we're all biased or blinded to a point by our perspective. And it's only when we can see the whole elephant and appreciate each other's parts that we can come together to do even better. No matter what our part is, it'll need all of us. Whether your focus is a MAD for OSA, or MAD or an appliance for grinding, or an appliance for teeth grinding, TMJ, whatever your role is, you need to be here, because it's important in the work we do. We, Dr. Tui and I, share a lot of patients, and we go back and forth about what to do. And Dr. Nebi, there's a bunch of people on here, and I look forward to hearing their comments. So to me, if I reflect back, these are not my quotes, but I say them often to patients. If you master your breath, you master your life. So the dynamics of how we breathe, and life is breath and breath is life. We only survive 3 minutes without breath, and that is what governs everything else. So I was fortunate enough to write a review paper. I can send the paper out if you'd like. It's called Craniofacial Sleep Medicine and the Important Role of Dental Providers in Detecting and Treating Sleep Disorder Breathing in Children. The bottom line is, you see these people all the time, and you would identify the issues and problems long before the ADHD and all the other things that they eventually come to the doctor for, or frank or florid sleep apnea. You're welcome to read the paper, and I hope this is the beginning of much more to come. So I just want to tell you about this little boy. I've seen this little guy intermittently over the last few years, and I referred him in 2020 because after trying CPAP, he couldn't tolerate it. I'm like, oh, we got to do something else. ENT said that there's no role for surgery. Look at him. He's a big guy, almost 13. I've clearly failed him because he isn't well. I'm not going to reiterate all the dental things because you all are much more skilled at that than I am. All I can tell you is he doesn't sleep well and doesn't breathe well and doesn't feel good. So like I told you, 20 years ago, we used to line all these kids up and get their tonsils and adenoids out. And now I don't even do that. I actually look for inflammation or treat their sleep. You're going to think I'm crazy, but I even look at other familial or ecosystem factors that could make the kid snore or not feel well, because the tonsils and adenoids are just one part of the puzzle. He had ear tubes at 5 years of age because he had recurrent ear infections, reflux and eustachian tube dysfunction. He gets migraine headaches. There's an elegant paper in 110,000 adolescents that says that if there's an adolescent who's a migrainer or has headaches, their likelihood of asthma and allergies is 4-fold higher. That makes sense to me because the airway is compromised with congestion or inflammation or size or whatever have you. you, and it's going to have downstream consequences. He had chronic and persistent nasal congestion. He's been diagnosed with asthma. He had a concussion. He has acid reflux, and he reports that he feels like something stuck in his throat, and he has neck pain and trouble falling asleep. Well, CPAP failed. I tried in what I know, and then it was like, okay, I need to group together all the rest of the people. And I'm like, listen, I want you to start exercising. I want you to start swimming if you're not physically fit. I want you to walk. I want you to be mindful of your diet. I want you to think and believe good thoughts. I told you it's about the ecosystem. To give you perspective for that, there's no way that a mango tree or a palm tree is going to grow in the Arctic. The environment has to be supportive, the airway in the tree. So we talked about all of that. When I saw him, I even put him on biologic for asthma, and he's on all these medications. Now they're talking about psychiatric meds and all of that because he's having trouble coping. And it's sad because instead of Hippocrates, what he said was use food as medicine. We're using medicine as food. And it's really sad. So Dr. Haidt saw him, and she worked on what she does, which is help him address the maxillary and mandibular discrepancy and address the gingivitis and his malocclusion while I worked on the medical stuff. So if I reflect back on my 20 years of experience, I'm going to say that airway, structure and function, the breath in its capacity, and sleep as its ability to treat or improve inflammation are critical. A trifecta of these three makes a difference between collapsibility or patency. And when I think about it, the airway is an engineering feat and a nightmare at the same time. I can't think of any substance or place in nature where in that region of, less than a half a foot, where the airway has to be collapsible to eat and stiff to breathe, and it has to get it right for every suck, every swallow, every breath. It's a lot, and to do it right at every step or juncture is difficult. And when we think about obstruction, Christian Guilleminault showed us that it's not just about the tonsils and adenoids or the hypopharynx, but it starts at the tip of the nose. That makes sense from a physics point of view in the Starling resistor model, that everything from anything like a septal deviation to collapsible choanae or collapsible columni of the nasal airways to a collapsible posterior pharynx, all of that would make a difference in how patent the airway is. And then the sleep quality, because there are people, you have seen this, I don't need to tell you, I'm preaching to the choir. There are people that have a sleep study where the AHI is 100 and they're not affected at all. You bring them to the office, worried about their health, and they're like, go away, I feel totally fine. Then there's others where their AHI is 5 and they can barely get out of bed and they're failing in life. So there's more to it than meets the eye than what the numbers say or what we know. So even as this structure and function story, we're learning more about it. We're, learning more about whether there might be a role if there's an arousal problem. Would there be a role for some sedatives? If there's a central drive problem, could there be a role for acetazolamide? Could you do something about the neuromotor tone? Is there a role for something like Inspire, where they actually innervate the genioglossus muscle? Does the sleep state make a difference? What does methadone do? There's a emerging literature about how marijuana might affect sleep. So all of those things come into determining whether the airway is open or collapsible. The tonsils we're learning about how fat may play a role, how to expand the airway with rapid maxillary expansion or Vivos therapy, how to even how to do tongue base reduction, sometimes in kids with Down syndrome, how to optimize the facial anatomy and airway, whether it involves separating the alveolar bones in the mandible and bringing the jaw forward, maxillary distraction, maxillomandibular surgery. There's all of these things that determine what happens to the airway. So clearly it is way more complicated, and we've learned a lot in the last 20 years. So to me, all these things would make a difference. Time and pressure changes nature, right? And it's important to think about that. You know, like going back to that patient I just told you, the 13-year-old, I was so invested in the tonsils and adenoids. And, you know, now I even tell them the tree is a lifelong thing. There's seasons and times, and the tree may change, but that characteristic or capacity for collapsibility doesn't change. So if we can change someone's earlobe and change it with time and pressure, if water can carve a pathway in this bed of rock, or if we can change the lower lip, is it conceivable that we can change the upper airway structure and function with time and pressure? And you all know this much better than me. It's just that we haven't proven the science in a meaningful fashion to show that expanding the nasomeatal complex or expanding the airway really cures sleep apnea. Not enough in a meaningful way, even though clinically you see some of these improvements. I actually just had a patient this morning. I read the sleep study for a dentist. The AHI is like moderate to severe. The MAD appliance is great and it makes sleep so much better, but the sleep study is worse and there's more hypoxemia. So the dentist is like, well, I don't know what to do because, you know, the MAD is loved and appreciated and the sleep quality is great, but the numbers are terrible. So I'm going to meet with them to talk about where else in the airway might this play a role and what needs to be done. So, you know, whether we're creating diamonds or, you know, making the airway different for aesthetic reasons or structurally changing the underlying nature of the bedrock, it all matters and we're all going to be needed to make this different. Okay, so, you know, lately, if you look at the stats, they're saying that 1 billion people are affected by sleep apnea. If I may be so bold, I'm going to say 2 billion people are affected. So what we're talking about when we talk about 1 billion, we're talking about diagnosis of OSA, but that's not the burden of suffering. I'd say the burden of suffering easily extends to 2 billion or more. You're all sleep people. If you do this, you see it every day. And once you see it, there is no unseeing it. It is rampant. It is an epidemic. It is bigger than COVID, and it is going to keep you busy till your last breath. And when we talk about costs associated with it, we're just talking about sleep apnea. We're not talking about suffering. If you talk about suffering, I'm going to say this is in the trillions. This is big, and you know it because you see it. You wouldn't be here if you didn't. And if I look at this data from 2016, I would say now, you know, you all aren't even represented, which is unfortunate. I think you would be in 2023. Dental sleep medicine are some of my best referrals. They ask the hardest questions and are very thoughtful. And look at the issues that are raised: drowsiness, quality of life, work performance. You're seeing all of this, whether it comes up as a dental issue or you find it in your office. And once you see it, it's not about Invisalign. I'm sorry, I love the technology. And if it's just about Invisalign, then we could just shut off the lights and go home. It's not. There is so much more. So I challenge you, urge you, cajole you, beckon you. When you look at the airway and you're thinking about whether they need Invisalign or not, please think about the airway, because the impact you're going to have on this family is, or the affected human and their family and their existence is significant based on these factors. So I've presented this before and I apologize if I'm being redundant, but this is so important and it helped me simplify sleep. So I'd like to share it with you. The way I think about sleep is like a light switch. We used to think of it like an on or off switch, but now we know that it's a dimmer switch. And we all oscillate through the day and night between wake and sleep. If you have someone who's awake and too awake and they're awake all the time or mostly, we call it insomnia. So sleep, trouble falling asleep, staying asleep, non-restorative sleep, unable to sleep, any of those things, that is insomnia. If you have someone that's very sleepy, that's hypersomnia, whether that's hypersomnia like narcolepsy, hypersomnia in terms of idiopathic hypersomnia or whatever. It's interesting, if we pull these apart on different spectrums of the same stick, is it possible that someone with sleep apnea present with insomnia? Absolutely, especially, sorry, I so apologize. That was my phone. Oh, I should have turned it off. I'm so sorry. Listen to my words, listen to what I'm telling you, but don't do what I do. I apologize. So if you look at someone with insomnia, can insomnia present as sleep apnea? Absolutely. You know what? In my mind, insomnia is not even a diagnosis till you ruled out obstructive sleep apnea, especially maintenance insomnia. I'm sorry, that's an airway issue. I have yet to find someone that proves me wrong, because central sleep apnea can present as insomnia or hypersomnia. If they have central sleep apnea and they have insomnia, they could be sleep deprived enough to sleepwalk. They could be sleep deprived enough to have night terrors. They could have sleep deprived enough to have nightmares. They could have periodic limb movements. Again, it could be an airway issue. I'm not saying it's always and only an airway issue, but it is big. You can only survive 3 minutes without breath and air. So it's got to be pretty critical in the functioning of the entire tree, whether we call it ADHD or we call it, whatever, doesn't matter. So insomnia is one spectrum, hypersomnia is another. That person can even oscillate between the two. So central sleep apnea can present with insomnia or hypersomnia, or they can, in a kid, you can have insomnia, behavioral insomnia of childhood. You can have hypersomnia, so the daytime sleepiness in a kid who sleeps everywhere and all the time. So can that adolescent who has hormones and congestion and has his nose and face growing out of proportion to his limbs, can he present with delayed sleep phase and circadian rhythm disorder? Absolutely. Could it still be an airway issue because he's congested and he had sleep apnea as a toddler and he had his tonsils and adenoids removed? And Dr. Guillemino already said that 13% have sleep apnea in adolescence, plus his dad and grandpa have sleep apnea. So could that school failure be DSPS, but the underlying root cause is sleep apnea? Absolutely. Is it insomnia during the day? Yes. Is it hypersomnia insomnia at night and hypersomnia during the day? Do we call it a circadian rhythm disorder? Absolutely. It's all the same. It's all the same. If the circadian rhythm disorder is bad enough, are they going to have periodic limb movements? Are they going to have night terrors, nightmares, sleepwalking, worse sleep apnea? Are they going to experiment more? Absolutely. All those things. So again, I urge you to question the role of the airway. In fact, even the cardiopulmonary coupling and all of that, I think the airway and respiratory control is integral. How much my airway or brainstem is fueled will determine how patient, kind, and loving I am. How much fuel I get to my prefrontal cortex in the way of oxygen and breath and support and airway clearance will like fuel in terms of oxygen and removal of toxins and sleep quality will determine how well my executive function is. So please, I love this slide and I hope it is useful to you. You're welcome to have it. Please use it. It has helped me appreciate and understand every sleep disorder from this viewpoint. So I'm going to tell you, you are so important. You're like the tusk of an elephant. Without the tusk of an elephant, elephants die. Without teeth, we have a shortened lifespan. Without an airway, we also succumb. There's not one sleep disorder that is exempt from airway structure and function. Just because we can't prove it doesn't mean it's not true. Okay? So there's a lot of sleep disorders. So the problem becomes, what do we want to do? We want to identify the airway issues and sleep apnea and treat it in a way that would impact long-term morbidity and mortality. So do I always treat the circadian rhythm? No, I know how to do chronotherapy. I know how to treat their DSPS, but what if their DSPS is a symptom of the underlying problem? No amount of retraining their chronotherapy is going to fix that, you guys. Okay, end organ dysfunction. What is affected? If the person is 300 pounds or 400 pounds, I'm sorry, they already have end organ dysfunction. Something in their life has failed them. The ecosystem, the tree, something has failed them to stop them from functioning. Whether my diagnostic test can identify sleep apnea or not, that is just another part of the puzzle. And to whom and how they present may affect how they access care and outcome, because the person that is sent to the dentist who makes the headaches better is very different from the person who comes to me with migraines, where I look for asthma and allergies and inflammation and airway issues and sleep apnea and family history and all those things. So we want wraparound care. We want it interdisciplinary. So if it's the tree root matters, the soil matters, the ecosystem matters, the environment matters, the season it is matters, all of that. And so the optimal timing is to treat and think. It's never too late. You are in the leading edge of creation and treatment and a better life. So once you see it, there is no turning back, people. This is our charge for our children and their children and so on, to make the world a better place. So what are we looking at? That's why our literature is so frustrating, because what are we looking at? We want to help the human function better. But how we do that? Do we do that by symptoms? So that human we talked about today, the MAD works. She feels great. She doesn't wake up. She sleeps well, but her sleep study is really bad. What are we going to do about that? Clearly, there's still something wrong. I'm going to help her with that, but I don't know what it is. I'll tell you, I've done it the other way. I have colleagues where we've looked at sleep image and we've done everything. We've treated their thyroid stuff and treated the airway and treated this and treated that. Their sleep quality is still terrible, and I have no idea what's wrong. I don't even know enough to know where it comes from or how to help, because this is also new. You know, when we think about how much time and effort has gone into healthcare research for daytime stuff, sleep takes 8 to 10 hours of our nighttime. What do we know about it? Minuscule, rudimentary in comparison. And then what do we use to measure it? You know, by the time they have morbidity and mortality, that kid who fails school, who's sleeping in the basement and can't get out of bed in the morning, we've already failed that kid. I've already failed that 13-year-old. He didn't get what he was supposed to, because if he did early on, he wouldn't be where he is now. He'd be doing way better. So what do we do? What do we do? And what do we use? A proxy? You know, what can we use? What measurable things are useful? It is useful to measure things. You know, people ask me if we can use questionnaires. Sure, you can sail like you did in 1492 with the stars and a compass probably, and the sun and the moon, but it's 2022. We can measure so much more. So measure allows us to be more precise and more accurate in our journey. So it is important. The thing is that the surrogate should be associated with clinical outcome, and the change in surrogate should be associated with change in outcome, but it isn't a one-to-one relationship. And unfortunately, the human is not like a spreadsheet. You can't have columns of positive and negative, and it doesn't balance out, unfortunately. So the AHI isn't good. We can't throw it out because we've done so much research related to it, but we know it doesn't correlate with PSG in adults for clinical measures. So maybe it's not the end all and be all, and we have to add in quality of life. But you know, if the airway is the marker and someone's well-being is the outcome, then maybe we need to change what we're measuring. But we still want to make the AHI better as a correlate. But maybe it isn't better all the time. It's no different than, you know, exercising and eating well. It's not just about eating well. Your macros matter if you're going to be a shredded, lean bodybuilder. It's not just about eating well and exercising. There's a lot that goes into the science, and I believe it to be the same with sleep. So we know that MAD works. You've heard this before. CPAP works, but if they don't use it, it doesn't work. MAD works too. If you use it, it works. If you don't use it, it doesn't work. And what is your gold standard? And would the ecosystem help? You know, I've even gotten kids to start playing instruments. The young ones that are floppy, you know, I'm like, swim, make your airway better. Sing, do whatever that you can do to make your airway more robust and strong. Swim, do gymnastics, bike, cycle. You know, it's like playing the didgeridoo. Can we start earlier? I came across this bottle. It's called a REM bottle that teaches people to suck like they did when they were babies. So you're forced to suck, and you know, suck the the bottle and make your tongue stick to the roof of your mouth. Could that help? Absolutely. Is that different from how I might consume my booster juice? Absolutely. So maybe that is the way to go. So you already heard about this. You know what? Untreated is bad, but maybe this could be a composite like the elephant. Maybe there's so many other things we could do, but we need your genius and your curiosity to figure out how to help that elephant, because we don't know. And, to me, success is where we help everyone feel well and feel good. The success to me is people feel well, they breathe well, they eat well, they grow well, and they can function and create and add to society in their own lives. That's what we're aiming for, not an AHI, not a specific measure. Do you feel well or not? Did you sleep well or not? And if not, what is going on? Look, it's everywhere. I already told you, there's not one place that is exempt. It doesn't matter. The guy in the middle, the only reason he doesn't snore with that small jaw is because he has an arm above his head. We've actually shown that in the sleep lab. People that have their arm above their head no longer snore. Isn't that crazy? Yeah, we've even shown it in kids because my tech noted that. And the mechanism behind that is you make the airway bigger by the bucket handle phenomenon when you have your arms above your head. It's so crazy. I'm not going to belabor this, but I look for stigmata of allergy. I look for the airway, features of the airway. I can even now tell you what side people sleep on, what they're doing in the night, because I've been blessed with the opportunity to learn from all the patients and the people I see. Even the Malin-Patty score, I measure it awake, in upright, and then I measure it asleep. I already know just from that they have OSA even before the sleep study. The question is, what am I going to do about it? If they have macroglossia, micrognathia malocclusion, I'm already thinking about the dentist and the maxillary expander and the myofunctional therapist. I never used to. Before 2020, I didn't, and now almost every patient has a dentist and a myofunctional therapist as part of my care. Does even smoking and vaping matters. All these things matter. If they're allergic to their dog and the dog sleeps in bed with them, there's limits to how much they can function. If this is a person who is sleep deprived every night and only sleeping 5 hours a night, watch Matt Walker's YouTube video called Sleep is Your Superpower. It will explain how men have smaller testicles and it prematurely ages them by 10 years from sleep deprivation. Does that make your airway more collapsible? Absolutely. It all matters. It all matters. So we already talked about some of this stuff. What do you do and what do we measure and how? And if you're confused by this talk about what we should be doing and why, it doesn't matter. Come join the club. Whether you support this or not, or whether you're a contrarian, we'll make the table bigger. Sit around so we can have discussions about what we're going to measure. I love sleep image. It's the first thing in anything we've ever measured that gives us the opportunity to measure stuff over time. Please ask Asola. She's on the call to come back and tell you all about it. It is a beautiful piece of technology. I use it to diagnose and follow treatment, and so can you. I don't want to discredit it, or not give it the due diligence it deserves, but it is a great technology and its concordance with PSG is 98%. And I don't say this just because, I love the technology. I had to beg them to let me sit on their team to say I have questions to ask. Okay, even the environment matters. Didn't I tell you that? So this is a patient, okay? Look at the first night with the saturation looks so different from the last half. I said, how could that be? It fell off. What happened? The dentist didn't provide the history. I said, I think he was drinking alcohol. Please ask. Sure enough, he had 2 or 3 drinks in the first part of the night, and the alcohol wore off. So all the environment matters. We can go through this in detail with you. Dr. Jane is in Ontario. You can reach out to him. I read kids studies. It doesn't matter. Reach out to people that can support you and keep asking questions. So going back to to that boy. I'm so grateful to Dr. Height. He couldn't wear the myofunction, he couldn't wear the therapy, the DNA, and now he can. He's down to 2 meds and he can wear it all night. And I can't wait to tell you what the next 3 to 5 years in his life are going to mean as he feels better and better. And you know this better than I. His malocclusion is better. His craniofacial profile is better. He's grown. You know, it's not just about the smile, it's about the airway. So what does the airway appliance? Vivos is one of them. You might have your other ways. It's okay. Bring your cases. Let's talk about it. One study by Karen Davidson showed that there was earlier resolution of bedwetting with a Vivos care guide. Bedwetting resolved in 120 days and 94% of the kids she looked at. Normally the spontaneous resolution rate is 15 per 100 per year. And Dr. Krieger presented a potential protocol at the AADSM about how we all need to work together. I'm so sorry, excuse me. How we all need to work together, and it's totally true. So the Vivos care, you know, it's an evolving technology. We talked about the airway, the structure, the function. We don't know what's best. We're learning just like you guys. Whether you're a prosomnus person or a Vivos person or something else, it doesn't matter. Just pay attention to the airway. And we have a paper just published in Sleep Medicine recently in 220 patients, with OSA. The AHI decreased by 49%. And 63% changed their OSA severity class, and they decreased their AHI by over 50%. There's only one adverse event, but it might not have been related at all. There were some mild side effects and none that resulted in treatment cessation. Okay, this is 13 hours a day, 13 months of therapy, 12 hours a day, average age 50. So 50, you know, I told you time and pressure matters. It doesn't matter if you're 2 or 22 or maybe 202. I don't know if we're blessed to live that long. Time and pressure changes things. So it's important. And when we saw it, certainly did make a difference. The severe, moderate, look, it cured some. Is it for everybody? No. You have to pick the right patient for the right treatment. And it matches up just as much as CPAP, mandibular advancement devices, Inspire. It's not bad. Again, whatever you're doing, please, whether you use Align or whatever, Invisalign, you fix the smile. That's great. Straighten the teeth, but please don't forget the airway. So you are critical, and you work with me hand in hand to make the airway better. And it's a two-way street, and we need each other to support sleep, airway, structure, and function. So it's important to treat the inflammation. If you treat the gingivitis and periodontal disease, I treat the nose and the throat and the airway. We do collaboration because the upper airway and lower airway drive each other crazy, and the gut's probably involved as well. The gut microbiome is super important. Systemic disease is important. Living your best life is about the airway, sleep, breathing, as well as the ecosystem that supports it. Pollution, a life that doesn't support you, let me be clear, I said the word life. A life that doesn't support you will result in sequelae. Whether it's sleep apnea or not is a matter of debate. I love these resources, Why We Sleep by Matt Walker, and Breath, The New Science of a Lost Art by James Nestor. I love this so much that I actually give every patient, kids and adults, exercises of James Nestor to say, look to what speaks to you. You must breathe better, effectively and differently, and do it well, because breath is your life. You fix that and you will heal from all of these things. I know that was long and I'm so sorry, but it's so important. I welcome any questions and ask me anything. If I'm not smart enough to answer it, there are so many smart people here today. I'm sure someone has an answer for you.